Well, the first thing is to first understand that KRAS mutations and BRAF mutations are different. So the other drivers, including EGFR, and all the fusions, do very poorly with immunotherapy. And if you give immunotherapy before those TKIs, it increases the toxicity. So in general, patients with drivers are not getting immunotherapy. Patients with KRAS and BRAF respond quite well. And the TKIs that are approved, sotorasib, and then for KRAS, G12C, and trametinib and dabrafenib for BRAF. There is a question as to whether those patients should get tyrosine kinase inhibitors first or immunotherapy first, because immunotherapy works in them. And in melanoma, a recent study showed that it was better to give the immunotherapy first before the BRAF TKIs. We don't know whether that's true in lung cancer, but it could be. Chemo immuno certainly has a higher response rate than even BRAF and dabrafenib. So there's some question about what should go first in those patients, but those patients should certainly get immunotherapy. Now, for the others, they should all get their TKIs first. Then the question is, when you fail the TKIs, should you get chemotherapy or should you get chemotherapy plus immunotherapy? And there are insufficient trials to determine that for sure. There was one trial called IMpower 150 that compared a 4-drug combination of Taxol, carboplatin, bevacizumab, and Atezolizumab to chemotherapy with bevacizumab alone. And there was 100 patients roughly that had EGFR mutations. And their outcome was better with the 4-drug combination, including Atezolizumab. That was not a pre-specified endpoint of the trial, and therefore the FDA has not approved that 4-drug combination for EGFR mutant patients. So at the time of progression, it's unknown what's best. Some patients, especially those who are young and in good shape and no contraindications to bevacizumab or atezolizumab, might get the 4-drug combination, whereas others would get chemotherapy alone, and if that didn't work, might get immunotherapy after that.